Hi, we are Group 1 and we're going to be talking to you today about dementia and delirium and how to treat these conditions in the elderly. This is just a short list of our objectives. We're going to be describing the differences of dementia and delirium. We're going to be discussing the different treatment options available for these conditions. We're going to explore the risk factors associated with each condition, and we're also going to be showing you firsthand accounts of some people that have had to deal with these conditions.
Hi, I'm Dolores, and my father had dementia. It was something I didn't want to acknowledge or deal with, and would often say to him, "Oh, Dad, it's this way," when he said it was that way. And I knew he was wrong. And often my brother, who seemed to realize that the problem was worse than I thought it was, would say, "Dolores, just agree with him because you're frustrating him and yourself because he gets upset because he doesn't remember things correctly." And I just never could go along with that. Then one day, we were sitting in my brother's home, and we started a discussion about trains. My brother's always, all his life, had trains, and he takes care of, he has them in his basement, and he builds little things. And uh, my father looked at him and says, you need to meet my son, Rich. He likes trains just like you do." And my brother looked at me, and I looked at him, and at that moment, I realized how bad the situation was. And he really just didn't know really what was going on around him.
So, this is a little introduction to dementia. Basically, dementia is a slow and irreversible disease that causes short term memory loss, and this can eventually progress to impaired language, problem with ADLs, and then eventual death. It's important to know that there is more than one type of dementia. And then there also has been opportunities that have been identified to reduce the progression of dementia. And it's important when we're treating dementia that we want to treat it effectively. And that includes reducing the incidences of delirium, to provide the effective antidepressant care, and to avoid any adverse events such as traumatic brain injury and stroke. Some risk factors for dementia include your age, a family history, cognitive impairment, hypertension, smoking, and diabetes. When we talk about the treatment of dementia, treatment options vary based on the type of dementia that the patient is presenting with. So for the purposes of this slide, we're going to be talking about the treatment of Alzheimer's dementia, which is the most common form of dementia. So the first type of drug that's out there is the cholinesterase inhibitors, and these work in a pathway and eventually stop the breakdown of acetylcholine, which is a neurotransmitter in your brain thought to be associated with dementia. There's 3 drugs in this class currently on the market. The first one is donepezil, the second one is rivastigmine, and the last one is galantamine. The second class of drugs available on the market that can treat dementia is the NMDA receptor antagonist. And there's only one drug in this class named memantidine. And this drug works by regulating the activity of glutamate, which is another neurotransmitter in your brain, and it's involved with memory and learning.
In my experiences working at Tampa General, I've seen countless episodes of delirium, and it's an extremely serious situation. Overall, we see it mostly in my setting in the elderly, and it's really a disturbance of many things, but in particular, we see delirium mostly in patients with 2 particular problems. One, infection, mostly urinary tract infections, I would say, being the most common, but also in acute pneumonia. Any acute infectious process certainly raises this suspicion for delirium. Also, we see delirium related to opiates, medications, of course. This is in particular where we get our pharmacists involved in reviewing the medications and seeing what may be the culprit. In general, we see three certain aspects, one including behavior changes in a patient. This could be mostly visual spatial problems, cognitive problems such as memory, but the main thing, it's a fluctuation of these symptoms that occur from day to night. Sundowning is a common word for delirium. It particularly raises its ugly head at nighttime where confusion becomes quite problematic. Also, we see hallucinations and illusions that the patient presents with. Paranoia. It's extremely disturbing both to families and also the staff to see patients go through these particular problems. It's highly prevalent in the elderly, as I've mentioned, and needs to be closely looked at because it can carry a high mortality, morbidity in our patients and needs to be addressed most promptly. Oftentimes, the treatment of delirium that we proceed with is treatment of the cause, which oftentimes is infection. So immediately we order a battery of what we call pan culture, where we do blood cultures and chest x-ray, we do urinalysis. We treat any infectious cause to eliminate the delirium, and as we progress through the delirium, depending on how severe it is, we may actually need to add medications as determined by the healthcare practitioner with the guidance of the pharmacist to try to manage these problems. And this is how we deal with delirium.
The next condition we're going to be talking about is delirium. And delirium is characterized by a reversible acute change in brain function, and it's typically fluctuating onset. The patient has an altered state of consciousness and also has an inability to concentrate and is very inattentive. There's two kinds of delirium. It's hypoactive and hyperactive. And as those words might describe, hypoactive patients are often lethargic, sleepy, and depressed, whereas hyperactive patients are often agitated. It's a common, very conditioned elderly patients, and also more common in elderly patients that are in like the ICU units or in the ER, and also patients that are residing in nursing homes. Some risk factors associated with delirium include advanced age, underlying brain conditions, sudden discontinuation of medications, infections, poor eyesight and hearing, and also sleep deprivation. As far as the treatment of delirium, there's pharmacologic and non-pharmacologic options for healthcare professionals when treating delirium. Most effective and most scientifically proven is the non-pharmacological options, and this includes making sure that the patient has adequate sleep, appropriate nutrition and fluid intake, identifying triggers that might be causing agitation, and limiting physical impairments. There are some pharmacologic options for delirium, but there really is little evidence to prove that any pharmacologic options are effective. Antipsychotics such as Haldol can be used when the patient is extremely agitated. However, benzos and other drugs in this class might actually worsen delirium. So it's important for you to be able to distinguish when is the right time to give medications like this. When looking at these conditions side by side, you would think that based on the characteristics that they're almost polar opposites and that it would be easy to identify the differences. However, delirium is often misdiagnosed as just worsening dementia. So it's important that as healthcare professionals, we're able to recognize these important characteristics for our patients. You can see here as far as the onset of dementia and delirium, dementia has a gradual onset, whereas delirium is very acute. Dementia is progressive and chronic, and delirium will start anywhere in hours or days to weeks. Dementia is irreversible. It's this gradual progression that we've been talking about, whereas delirium can be reversed. And it's important to know that there's often underlying causes such as infection that can be causing delirium. As healthcare professionals, it's super important for us to be able to know the difference between delirium and dementia. Often, delirium is misdiagnosed as worsening dementia, and the treatment options that may be used for worsening dementia can also worsen delirium. So it's really important to know the differences. We have to rule out any underlying causes of delirium, as discussed: high fever, infections, trauma, substance abuse, substance withdrawal. All of these things can cause delirium. It's important to be aware of the different physical findings. Again, making sure that there's no underlying infection. What's interesting is that in delirium, there's an abnormal EEG, whereas in dementia, there's a normal EEG. So it would be important that if you were trying to distinguish between these two conditions, that you would get an EEG ordered. There's also different psychological findings. Delirium patients often have poor orientation to person, place, and time. They have hallucinations. They're often anxious and agitated. And we can see some of these symptoms worsening at night, whereas dementia, there's no psychotic symptoms typically early in the disease. In conclusion, dementia and delirium are very different conditions that both present in the elderly. Dementia is often progressive and irreversible and is associated with memory loss. Delirium is often more acute and has an underlying cause. It's important for us as healthcare professionals to be able to identify the differences between these conditions and know how to make the correct treatment plan for our patients. We want to thank you for taking the time to watch this video. If you have any questions or concerns, please direct them to jscott18@health.usf.edu, or you can contact any of the members listed on the first slide. These are our references used for this presentation if you would like to look at any of the information we used for our presentation.